Good evening to everyone and welcome to today's wonderful evening with Dr. Murali Bharadwaz. Geeta, Sneha, Vidya Sagar and many more who are all online. Geeta, is my voice clear and loud?
Yes, sir.
Is my voice loud and clear for all of you? Yeah. Can the online students can punch whether my voice is loud and clear for all of you? So, good evening to everyone. Haripriya, Sneha, Vidyasagar and everybody. So, let us make the great beginning like every day that we take up 100 points, we do a quick revision and once more ask it as questions and you are supposed to give the answers. That's how every day evening at 6 o'clock we all meet and do the revision. So today my focus is going to be a bit on neurology and few important concepts in neurology, and then from there we progress forward. So doctor, there are certain structures in the neurology and their lesions. Earlier also we have discussed this. Once more, we will focus on that. Now, if you look at basal ganglia, what are the lesions that occur in basal ganglia? Whenever basal ganglia lesion is there, you get a thing like Parkinsonism. So what type of tremor is Parkinsonism? It is an asymmetrical rest tremor. A tremor that occurs in rest, and also it is asymmetrical, very characteristic feature. Basal ganglia lesions can lead to chorea, epitosis, and what are the various basal ganglia lesions? Parkinson's, Huntington's, Wilson's disease, they're all the ones which affect the basal ganglia. Next, subthalamic nucleus. Typically, a lesion of the subthalamic nucleus lead to the clinical symptoms on contralateral side. Suppose my right subthalamic nucleus is affected, then my left side lesion will come. I mean, clinical symptoms. So what is the clinical symptom of subthalamic nucleus? It's called hemibalismus. Hemibalismus means it is like a big bat which is winging its wings like that, flipping its wings like that. Grossly, there is a abnormal movement which is called hemibalismus. But subthalamic nucleus on the right side will lead to left side, that is contralateral hemibalismus. That is what you need to remember. Then mammillary bodies. Typically mammillary bodies, whenever they are involved, we get Wernicke-Korsakoff syndrome. So what are the classical features of the Wernicke-Korsakoff, doctor? Confusion, ataxia, nystagmus, ophthalmoplegia, both retrograde and anterograde amnesia, confabulation, and personality changes. So these are the classical features of Wernicke-Korsakoff, as all of you know very well. Amygdala. In which clinical condition amygdala can get affected? Amygdala is a structure very close to temporal lobe, medial part of temporal lobe. So typically whenever HSV1 encephalitis occurs, that can lead to development of amygdala. So any amygdala lesion will lead to Kluver-Bucy syndrome. Can anybody tell me what are the components of Kluver-Bucy syndrome due to amygdala involvement in HSV encephalitis? Anybody? Vidyasagar, Sneha, Samir, Haripriya, Geeta. Kluver-Bucy syndrome. Have you heard of this? Whenever amygdala get involved, the person gets a disinhibited behavior. He will develop hyperphagia. He will start eating everything. Hyperphagia, hypervirality, hypersexuality. These are all the features of the amygdala lesions, is what you need to remember. Then dorsal midbrain. What does the lesion lead to? Typically, dorsal midbrain can be involved in stroke, hydrocephalus, and in penialoma. These are the three conditions that affect the dorsal midbrain. Dorsal midbrain lesions, dorsal midbrain का एक importance है. Remember, see, you know what is horizontal gaze. Right to left, left to right, right to left, left to right. You can be able to move your eyes. That is called horizontal gaze. Above to below, below to above, above to below, below to above. If you ask the patient to look with both his eyes, that's called vertical gaze. Pons is the center for horizontal conjugate gaze, and dorsal midbrain is the center for vertical gaze. So a patient who is having Parinot syndrome because of dorsal midbrain lesion will have a vertical gaze palsy. That's what you need to remember. Similarly, midbrain is also the place where you have all this Edinger-Westphal nucleus, prepectal nucleus, and all that. That's the reason the pupillary light near dissociation is a feature of dorsal midbrain involvement in Parinot syndrome. So the lid will show retraction. There is a convergence retraction nystagmus, convergence retraction nystagmus whenever there is a dorsal midbrain lesion. So these are the points you have to be very, very, very sure about it, doctor. The dorsal midbrain lesions. Now, reticular activating system. Typically, you have reticular activating system in the midbrain. Anything that affects that will decrease our arousal, wakefulness, and that lead to development of coma. Then comes cerebellar hemisphere. So typically, cerebellar lesions lead to intention tremor, limb ataxia, loss of balance, etc., etc. And always remember, cerebral cortical lesions lead to opposite side, contralateral side hemiplegia, right? Suppose if my right cerebral hemisphere is involved, I get a problem in my left side. Whereas cerebellar lesions lead to ipsilateral deficits, same side deficits, and the person will fall towards the side of the lesion. That is what you get in the cerebellar hemisphere, is what you need to remember. Then cerebellum has hemispheres, and cerebellum has one central part called vermis. So always hemispheric lesions of the cerebellum affect the limbs, right? Lateral limbs. Whereas cerebellar vermis involvement lead to truncal ataxia. The trunk get affected. So it affects central body. The person will get ataxia, truncal ataxia. His gait become wide-based. It's called drunken sailor's gait. And the patient will develop nystagmus. And typically cerebellar vermis lesions are because of a chronic alcohol use. There's a degeneration of the cerebellar vermis. Then comes the red nucleus in the midbrain. There are two things you need to remember. Decorticate posturing, decerebrate posturing. Whenever midbrain get involved, whenever the red nucleus is involved, then you get two types of things called decorticate posturing, decerebrate posturing. So when you get decorticate posturing, if the lesion is above the red nucleus in the midbrain, you get decorticate posturing. So what is meant by decorticate posturing? There is a flexion of the upper extremities and extension of lower extremities, which is called decorticate. Decerebrate means extensor posturing. Where do you get it? Whenever there's a lesion is at or below the level of red nucleus, you get decerebrate posturing. And typically in this, there is an extension of both the upper and lower extremities. So that's what you need to remember. So there is a extension of both the upper and lower extremities in decerebrate posturing, whereas decorticate means upper limbs are flexed but lower limbs are extended. So how will you remember? Decorticate, upper limbs are flexed, lower limbs extended, whereas decerebrate, both upper limbs and lower limbs are extended. So how will you remember? Decor, cor means heart. So when you flex your upper limbs, your palms will come nearer your heart. That way you can remember. So decorticate posturing means upper limbs flexed, lower limbs extended. Decerebrate is both upper and lower limbs are extended. Decerebrate is a lesion at or below the level of red nucleus. Decorticate is lesion above the level of the red nucleus. Between the two, which has a bad prognosis? When both your upper and lower limbs are extended, you are ready to go into the graveyard. So that's why you can remember decerebrate posturing. Whenever it is at or below the level of the midbrain, if the lesion, then that has got a worse prognosis. These are the points you need to remember quickly. Now, it is the time to awaken and it is the time for checking how much you understood. Tell me, doctor, right subthalamic nucleus leads to what clinically? Come on, please open up your mics and speak. Right subthalamic nucleus.
Left-sided hemibalismus.
Yes, doctor. Right subthalamic nucleus, what does it lead to? Vidyasagar, Geeta, Haripriya, what happened? I'm not able to listen your voice, doctor.
Left-sided hemibalismus.
Very good, very good, very good. So good to see Jay Karthi, Josna, and many more for all online. Very good. Every day evening, doctor, 6 to 7 p.m. you have Dr. Murali Bharadwaz. In 1 hour, I will revise around 100 points for you. And after this session is over, you need to go back to the Incus Learning app. There are 5,000 video lectures, 1 lakh PowerPoint slides, 70,000 MCQs in the form of flashcards, and 3,500 quiz tournaments. All is available in the Incus Learning app for you to do the revision. So after this session, please do the revision after getting inspired. Good to see on the YouTube today, Jitendra Verma is also participating. So his answer is left hemibalismus. Very good, doctor. Now, tell me what are all the features of Wernicke-Korsakoff? Wernicke-Korsakoff syndrome. So what are all the clinical features, doctor? Geeta,
Confusion, ataxia,
good,
retrograde and anterograde amnesia,
super,
personality changes,
very good. Confabulation and nystagmus. Confabulation means just like in viva voce, if examiner asks you a question, no, you feel that you know the answer, but something, you will be beating around the bush. That is a thing called confabulation. Tell me one condition where you get Kluver-Bucy syndrome.
amygdala,
Amygdala involvement, but what is the etiological cause for Kluver-Bucy?
HIV-induced encephalitis.
HSV, herpes simplex virus encephalitis. Very good. And what are the clinical features of Kluver-Bucy? Hyperphagia, hypersexuality, hyperorality. Tell me what is the center for horizontal gaze and what is the center for vertical gaze in our brainstem?
For horizontal gaze, it is pons, and for vertical gaze, it is dorsal midbrain.
Very good. So, what is the syndrome where dorsal midbrain lesion is there called as? Parinod syndrome. P-A-R-I-N-A-U-D. Parinod syndrome is what you need to remember. Now, between cerebellar hemisphere and vermis, where do you get a truncal ataxia as a feature?
Vermis.
Very good. And between decorticate, decerebrate, tell me the differences. Which is below red nucleus, which is above red nucleus, which has got a bad prognosis. And decorticate, decerebrate, tell me what is a typical upper limb, lower limb posture. Between decorticate and decerebrate.
Decorticate, lesion is above the red nucleus.
Very
Decerebrate,
good.
lesion is at or below the red nucleus.
Good.
Among decerebrate and decorticate, decerebrate has bad prognosis.
Correct.
And in decorticate, there is a flexion of upper limb and extension of lower limb, whereas in decerebrate, both upper limb and lower limb, there is extension.
Excellent, excellent, Geeta. Very good. Everybody else also can answer, doctor, please, because a lot of times what happens now, when you are passively listening to a lecture, it is so boring, you know. But if you are ready and alert to answer on the same points that I tell before, then you will be very alert. And that is how you have to learn, right? That's how you have to, in a group, need to understand, reproduce, recall, repeated repetition. That's how you will be able to master the subject, right? Now, if you look at the ischemic stroke, the most vulnerable parts in the brain for the ischemic stroke are hippocampus, neocortex, Purkinje cells in the cerebellum. They are the most vulnerable areas. Typically, an irreversible neuronal injury. It begins after 5 minutes of hypoxia to the brain. So sensitive is the brain to hypoxic injury. And whenever a person has got a stroke, what is the investigation of choice? One of the favorite questions of the examiner. Your answer should be non-contrast CT. It is not contrast CT, it is non-contrast CT. Why? Because if you do non-contrast CT, you can exclude hemorrhage. Because if you pass contrast, no, hemorrhage also picks up contrast, and your what you call ischemic area also will be shown. But if it is a non-contrast CT, then if it is a hemorrhage, it will be shown like a white area. So to exclude hemorrhage there are two types of strokes, hemorrhagic stroke and ischemic stroke. Whenever the person has got a stroke, the first investigation of choice would be non-contrast CT to exclude the hemorrhage. Because only if the hemorrhage is not there, then only you can give the thrombolytic agent like TPA, tissue plasminogen activator. Now, after how much time CT can detect the ischemia? Suppose if I get the stroke right away, you parade me to the CT scan, you can't see my ischemic changes. It takes 6 to 24 hours. Diffusion weighted MRI is much more sensitive. Diffusion weighted MRI. Because within 3 minutes to 30 minutes from the onset of stroke, it can detect. So diffusion weighted MRI can detect the ischemia more sensitively within 3 to 30 minutes. Whereas for the ischemic changes to be detected by only the CT, it takes 6 to 24 hours. So what will you do after this class is over? Go to the Google Images. Check how diffusion weighted MRI ischemic brain looks like and how on a plain CT ischemic brain in a stroke looks like. Now there are some histological changes that occur once the brain suffers ischemia. So first 12 to 24 hours, there will be snowflake cytoplasm with pycnotic nuclei. It's called red neurons. 24 to 72 hours, you will find neutrophils and necrosis. 3 to 5 days, macrophages. 1 to 2 weeks, it takes reactive gliosis, which is because of the astrocytes. And there is a vascular proliferation. And by the time a glial scar is formed in the brain after ischemic injury, it takes about 2 weeks of time. That is what you have to basically remember. Now, if there's an ischemic stroke, what type of necrosis we see in the brain? Liquefactive necrosis. In the heart, we find coagulative necrosis. So, how do you treat ischemic stroke in the brain? We give tissue plasminogen activator. So, what are the prerequisites before you thrombolyze a patient with TPA? Once more, imagine yourself as a neurologist doctor, please. Because ischemic stroke, hemorrhagic stroke. Every minute you have an ischemic or a hemorrhagic stroke in the pan-India, in the India. After the class is over, you check how many strokes happen every day. So, the most important prerequisite is, did the patient arrive in the golden period of time? That is within 3 to 4.5 hours of onset. Second, there should be no hemorrhage. There should be no risk of hemorrhage. So that is what you need to do. Check before you give TPA. The other alternative is, ischemia is all because of a big thrombus. So if it is a big thrombus, then thrombectomy is a choice. Then, what are the risk reducing measures in ischemic stroke? You can give aspirin, clopidogrel, control the blood pressure, control blood sugar, lipid, smoking should be stopped. And there are certain things that increase the risk of ischemic stroke. What are they? Suppose if the patient has atrial fibrillation, there is a clot formed in the heart and that will float to the brain. You have to control fibrillation. Similarly, if somebody has atherosclerosis and carotid artery stenosis, that also lead to a floating thrombus, which increases the risk of ischemic stroke. Then let us talk about transient ischemic attack. What is the definition of TIA? A brief reversible episode of the focal neurological dysfunction without any acute infarction. There is a focal neurological dysfunction like weakness of the limb, etc. But it is brief, reversible, and still there is no acute infarction. That means if you do MRI, diffusion weighted MRI, there is no lesion. And most of the TIAs, by definition, they resolve in less than 15 minutes. That's what you need to remember. And whenever TIA is there, patient can develop amaurosis fugax. What's the meaning of it? Amaurosis fugax is transient visual loss. Is what you need to basically remember. And it is because of retinal artery emboli from the carotid artery disease. So amaurosis fugax can also be a presenting feature of TIA, is what I want to underscore to all of you. Now, doctor, one of the favorite questions of the examiner is different types of strokes. You have to be 100% sure. Anterior artery, middle cerebral artery, lenticulostriate artery. These three strokes are called anterior circulation. Posterior cerebral artery, basilar artery, anterior inferior cerebral artery, posterior inferior cerebral artery, anterior spinal artery. These strokes are called posterior circulation. You have to be 100% sure about each of them. Now I'll quickly tell you. Anterior cerebral artery. Typically, what will be the symptoms? Anterior cerebral artery. You know very well, anterior cerebral artery, middle cerebral artery arise from internal carotid artery directly. Whereas posterior cerebral artery arises from basilar artery, which is formed by combining of two vertebral arteries. The two vertebral arteries combine to form basilar artery. Basilar artery divides into the posterior cerebral arteries. So that is the reason posterior cerebral artery, basilar artery, anterior inferior cerebral artery, posterior inferior cerebral artery, anterior spinal artery, these are all called posterior circulation. So anterior circulation means anterior cerebral artery, middle cerebral artery, and lenticulostriate artery. So if you take anterior cerebral artery involvement, there is a contralateral paralysis, contralateral lower limb paralysis, contralateral lower limb sensory loss. For example, if my right anterior cerebral artery is involved, my left lower limb will show paralysis and sensory loss. There is also urinary incontinence because anterior cerebral artery supplies frontal lobe. Frontal lobe is having the center for voluntary bladder control. That is the reason there is a urinary incontinence whenever anterior cerebral artery is involved. Then middle cerebral artery. Typically, middle cerebral artery supplies the upper limb and face, whereas anterior cerebral artery supplies lower limb. So, similarly, middle cerebral artery also supplies temporal lobe, which is having Wernicke's area, frontal lobe, which is having Broca's area. So these are the things supplied by the middle cerebral artery. So middle cerebral artery lesions lead to contralateral paralysis, contralateral sensory loss of the contralateral face and also upper limb. So contralateral hemiplegia with upper limb involvement and face involvement on the contralateral side is what you see with middle cerebral artery. Similarly, left middle cerebral artery involvement will affect the left hemisphere, which is the dominant hemisphere in the right-handed people. Hence, you get aphasia when the left middle cerebral artery is involved. Similarly, right cerebral hemisphere is non-dominant. Right cerebral hemisphere is non-dominant. So whenever the right middle cerebral artery is involved, non-dominant hemisphere is involved, and that leads to hemi-neglect. The person forgets to wear half of his body. He doesn't remember that he has a half body. That's a problem. Similarly, whenever middle cerebral artery is involved, temporal lobe is involved, you get Wernicke's aphasia. Then temporal lobe involvement also lead to right superior quadrant visual field defect. Right superior quadrant visual field defect will occur, is often associated with Wernicke's aphasia. All these things you can see in the hospital, because middle cerebral artery, without a 5 to 6 patients of middle cerebral artery involvement, there is no hospital clinical wards at all. So if you go to the clinical wards, you can see the right middle cerebral artery involved, the middle cerebral artery involvement with Wernicke's aphasia, with right superior quadrant visual field defect because of the temporal lobe involvement. Then comes lenticulostriate artery. It supplies striatum and internal capsule. So internal capsule is involved. That's the reason contralateral paralysis will be there. And there will be, what is the main difference between lenticulostriate and middle cerebral artery involvement? If it is a lenticulostriate artery involvement, there are no cortical signs like heavy neglect or aphasia or visual field loss. All those things you don't see. Only what you see is contralateral paralysis. So lenticulostriate artery can lead to a pure motor stroke. Commonly, it only leads to pure motor stroke. And what are the common location of the lacunar infarct? Generally, lacunar infarct is because of a microethydoma or a hyaline arteriosclerosis. It is also called lipohyalinosis, is what you need to remember. And very often it is an unmanaged hypertension. Secondary to that, you get lenticulostriate artery involvement, is what you need to remember. मेरे प्यारे भारतवासियों, नींद से जागो और फटाफट मुझे बताओ. Any one of you quickly tell me what are the 3 arteries which are called anterior circulation? What are the 5 arteries which are called posterior circulation? Come on, doctor, wake up. Geeta, what are the vessels in anterior? What are the vessels in posterior circulation?
Anterior includes anterior cerebral artery, middle cerebral artery, and lenticulostriate artery.
Super.
Posterior includes posterior cerebral artery, anterior inferior cerebral artery, posterior inferior cerebral artery, anterior spinal artery.
Very good, very good. So excellent, doctor. So posterior cerebral artery, basilar artery, anterior inferior cerebral artery, posterior inferior cerebral artery, and anterior spinal artery. Excellent. Contralateral lower limb paralysis and urinary incontinence. They are the features of
Anterior cerebral artery involvement.
very good, very good. And whenever Wernicke's aphasia is there, what is the kind of visual field defect you get? What is the kind of visual field defect?
Superior quadrant.
Right superior quadrant anopsia. That's what you get. And where is Wernicke area and where is Broca's area? Which lobe?
Broca's area in the frontal lobe and Wernicke's area in the parietal.
Correct. Temporal lobe.
Temporal.
Good, good. Now, let us talk about the posterior circulation. In posterior circulation, if you take posterior cerebral artery, it supplies occipital lobe. Occipital lobe. And occipital lobe involvement lead to contralateral hemianopia with macular sparing. Contralateral hemianopia with macular sparing. Similarly, posterior cerebral artery involvement, a right-handed person, left side, which is the dominant hemisphere. So in the dominant hemisphere, all the area extending to corpus callosum, splenium, they're all supplied by posterior cerebral artery. So whenever dominant hemisphere is involved, when posterior cerebral artery is affected, that lead to alexia without agraphia. Then, whenever the non-dominant hemisphere is involved in posterior cerebral artery stroke, you get prosopagnosia, inability to identify the faces, is called prosopagnosia, which is a feature of posterior cerebral artery involvement. Geeta, will you tell me back what are all the posterior cerebral artery lesion clinical symptoms?
Contralateral hemianopia with macular sparing.
Very good.
And if dominant lobe is involved, then
Alexia
without agraphia. And if it is non-dominant, then prosopagnosia.
Super, super. Now, coming to bachelor artery. So as I told you, the two vertebral arteries combine to form bachelor artery, and bachelor artery divides into two posterior cerebral arteries. So bachelor artery forms a vascular backbone to the brainstem basically. Brainstem has midbrain, pons, medulla. Top midbrain, middle pons, lower medulla. So whenever bachelor artery is involved, the pons, medulla and lower part of the midbrain are involved. So whenever midbrain is involved, we are worried about reticular activating system. But sometimes the reticular activating system is spared. If the reticular activating system is spared, consciousness is preserved. But if reticular activating system is involved, then consciousness is gone. Coma, patient goes into coma, means the midbrain is involved and reticular activating system is involved. That is the meaning of coma. Then corticospinal tract, corticobulbar tract. Corticospinal means pyramidal tract, it is also called. From the brain to the Andrehorn cells in the spinal cord, the connection is corticospinal. Similarly, the cranial nerve nuclei in the medulla are called bulbar nuclei. Once more, all of you should remember, what are the cranial nerve nuclei located in midbrain? Third, fourth. What are the cranial nerve nuclei in pons? Fifth, sixth, seventh. Fifth trigeminal, sixth abscens, and seventh is facial. Is typically there in the pons. Then 8th, 9th, 10th, everything else is there in the medulla. So when bachelor arteries, so what is corticobulbar? Corticobulbar means always the medullary cranial nerve nuclei, 8th, 9th, 10th, 11th and all, which are important for your swallowing, laryngeal muscles, pharyngeal muscles and all that. It is all closely controlled by our brain with the corticobulbar tract. Similarly, our Andrehorn cells are all controlled. Andrehorn cells will control all our muscles by the origin of all the spinal nerves. But Andrehorn cells are controlled by the inhibition caused by the upper motor neuron, that is the cerebral cortex. So corticospinal tract controls the anterofoncyles, corticobulbar tract controls the cranial nuclei in the medulla. So whenever basilar artery is involved, this corticospinal, corticobulbar tract, which are passing through the brain stem, they get affected. And that lead to quadriplegia, all the four limbs gone, loss of voluntary facial movement. Whenever we are angry, whenever we are laughing, etc., there are some voluntary facial movements. They are gone. Similarly, voluntary movements of the mouth, tongue, they're all gone because the corticobulbar tract involvement. Similarly, basilar artery involvement also affects the cranial nuclei that control the eye, because there is an area called paramedian pontine reticular formation, PPRF, paramedian pontine reticular formation, which is located in the pons. Pons is a part of the brainstem. Brainstem is supplemented by basilar artery. So whenever basilar artery is involved, pons is involved, paramedian pontine reticular formation is involved, then your horizontal gaze get affected. So there is a loss of horizontal eye movements whenever basilar artery involvement is there, is what you need to remember. And similarly, whenever basilar artery is involving the midbrain, lower midbrain, if at all reticular activating system is involved, then coma will come. If it is spared, consciousness is preserved. Then similarly, pons has one importance you should all remember. Pons is also called the center for efferentiation. All our motor activity leaves our brain, the cerebral cortex passes to the midbrain, through the brainstem, and leaves through the pons. Whenever pons is involved, then the patient will develop loss of all motor activity. So all the four limbs will go into quadriplegia and horizontal eye movements are affected. The only thing left over in his face is his vertical gaze is still preserved when the pons is involved. And that is called locked-in syndrome, is what you need to remember whenever pons is involved. Whenever the basilar artery occlusion is there, is what I want to underscore to all of you. So this is in brief, Doctor, what all that we plan to discuss today. I hope you all enjoyed the class, and once more tomorrow evening we will all meet up, and thanks for joining today's wonderful evening. Good night.